Yeah.
Yes. So good afternoon to one and all. The topic today I'm going to discuss is the need to critically look at numbers in blood counts. I'm Dr. Lakshan Raj from Dr. Balasubramanian Research Unit from Chitest Hospital. So here the history goes like it's a 3-month-old child came to us with complaints of fever for 1 week. Maximum document temperature was 102. There was no other focus of infection. The birth history, it was a term child born to a primary gravida mother, 3rd-degree consanguineous marriage, and a birth weight of 3 kgs. The child had significant history of neonatal hypoglycemia. And for this history of fever for 1 week, the child was evaluated for the same with outside and which showed a hemoglobin of 9.7 with a total count of 5,600 and a neutrophil count of 16%, when the ANC was around 800. The platelet was 4 lakhs and CRP was 35, and child was empirically started on IV cefotaxime. But in view of persistent fever spikes, the child was referred. So examination-wise, the child had failure to thrive. Weight at admission at 3 months of life was only 4.1 kgs. There was only 1 kg weight gain since the last 3 months. The child had cherubic faces. On per-abdominal examination, the abdomen was distended with firm hepatosplenomegaly. So after sending baseline investigation, the child was started on IV meropenem in view of neutropenia and previous exposure to antibiotics. So here the child baseline evaluation showed hemoglobin was 9.6 with a total count of 6,500 with a neutrophil count of only 4% and a CRP of 190. The renal function test was normal, but the ionized calcium was highly elevated, which was 1.52. And the liver enzymes AST ALT was also very high. The SGOT was 467 and SGPT was 151. And the gamma glutamine transferase also 910. So with this, the concerns first, the child had failure to thrive, child had 3rd-degree consanguineous marriage, child had a firm hepatosplenomegaly, history of neonatal hypoglycemia was there. There was neutropenia with a high CRP and elevated liver enzymes and elevated ionized calcium. So the working diagnosis in this child was either a storage disorder, like with glycogen storage disorder along with underlying sepsis, or a primary HLH. So further evaluated, the lipid profile showed very high triglyceride values and elevated LDH and uric acid values with lactic acidosis. And for ionized calcium elevated, we did a vitamin D and parathyroid hormone, which was very high, and secondary hyperparathyroidism was present. Ultrasound abdomen showed hepatosplenomegaly with nephromegaly with nephrocalcinosis. Echo and ophthalmic evaluation was normal. So in this child with high triglyceride value with hyperuricemia and elevated uric acid levels and hepatosplenomegaly, a clinical diagnosis of GSD was made. Since the child had a neutropenia, there was a very high suspicion of clinical diagnosis of type 1B GSD. So the blood culture also within 40 hours grew enterococcus, but the sensitivity was awaited. Initially, it was thought either it could be a contaminant or not a pathogen, but since the child had an underlying neutropenia and a very high CRP without any focus, so we started the child as on AMPI and Genta. The sensitivity pattern, it was sensitive to chloramphenicol, linezolid, teicoplanin, and vancomycin. It was resistant to gentamicin and ampicillin. So we were not able to start on vancomycin because the child had nephrocalcinosis and linezolid because of leukopenia. So we started the child on teicoplanin, and the repeat counts showed 2,200 total count with platelet neutrophil of 35%. So for the GST part, we took a gastroenterologist opinion. We did a overnight fasting glucose levels. And during fasting for 4 hours, child developed hypoglycemia. So the child was stopped breastfeeding and started on iso milk feeds. And nephrocalcinosis, the child ionized calcium, repeat ionized calcium also was very high. Urine calcium create ratio was more than 2. So the child was started on palmitonate injection. And after 7 days of IV antibiotics, repeat cultures was sterile. And after starting on iso milk feeds, after 10 days, repeat triglyceride values and lactate values were in the improving trend. So the child neutrophil count improved and CRP came down to 18. So this is the genetic sequencing which showed a pathological variant of confirmed diagnosis of glycogen storage 1B. So this is a case series where around of pediatric case series where 7 patients of GSD type 1B was followed up with a long follow-up study, and among them majority of them, nearly 6 of them had suffered from neutropenia and required granulocyte monocyte colony stimulating factor. So 2 patients developed inflammatory bowel disease, 6 patients 6 patients remained alive at this point of time, and 1 died at the age of 14 years, 9 months. So a short brief note on GST with neutropenia. The incidence of glycogen storage type 1 itself is a very rare disease. The incidence is only 1 among 1 lakh live births. And that also 80% is usually type 1A, only 20% belongs to the type 2. And the basic pathophysiology or pathogenesis behind neutropenia and GST type 1B is still not well understood. The majority of the hypothesis, either it could be due to the oxidative stress or enhanced endoplasmic reticulum stress, and that leads to apoptosis, leading to neutropenia and neutrophil function defect. So neutropenia is noted typically after the first few years of life, resulting in recurrent bacterial infections and dental infections. So the treatment for the neutropenia and GST type 1B should be treated with granulocyte colony stimulating factor. It increases the neutrophil count, decreases the frequency of infection as well as the severity, and improves the inflammatory bowel disease symptoms. Since the basic pathophysiology is surrounding reactive oxygen species, it plays an important role in activating the apoptosis in neutrophils of the patient. It is suggested that antioxidant therapy might be beneficial. So supplementation with vitamin E has been shown to increase the neutrophil count, decrease the frequency of and severity of the infections. Those individuals who are on GCSF should be monitored closely for the changes in the spleen size, especially in the absence of infection and signs of myelodysplasia. There's a newer drug called empagliflozin, which is used in adults for especially as anti-diabetic. It helps in excreting this toxic metabolite, that is 1,5 and hydroglucital phosphate, which is usually accumulated in case of neutrophils in this G6PD deficiency. Glycogen storage disorder type 1B. And by starting on this drug, it helps in improving the neutrophil number as well as the function and reducing the frequency of bowel flush. So the take-home message is a good look at the total count and differential count is very essential. It helps us in guiding us to make an empirical diagnosis from either infection to immunodeficiency. And patients with G6, GSD type 1B and neutropenia and severe infections has to be started on GCSF. It should not be started in every other neutropenia, especially in GST type 1B. And in management of GST type 1B, a diet low in fructose and sucrose is recommended, with limiting the intake of galactose and lactose to 1 serving per day. And those children with GST type 1 and children 1 to 2 grams of cornstarch per day, body weight, every 3 to 4 times per day is recommended. Thank you.
Thank you, Dr. Lakshan. Very good talk. I love the way you maintain time also. The talk was very nice. We'll go to the next speaker. Unfortunately, as